We're going to talk a little bit about some of the specific drills we do in our role here as being a vestibular therapy specialist. In other words, we treat a lot of people with damage to the inner ear or the brain that can give them marked balance problems, as well as quite a bit of patients with vertigo, that abnormal sense of motion. And typically with our patient population, that's from damage to an ear, but many things can cause that. The perspective on that is that gets back to what we talked about, sensory integration. You have three primary senses that help you keep your sense of where you are in space: your vision, your sense of touch and pressure, which this provides quite a bit of, as well as that sense from the inner ear. Your inner ear vestibular organs provide sense of head tilt and head rotation. For most of our patients, when they have a damage to the ear, that throws off the signal the ear is sending to the brain. It becomes asymmetrical. The problem there is that if the brain's expecting normal symmetrical input, then your ear sense doesn't match up with what the other two senses are telling it. Primarily, when we define vertigo, we talk about a vestibular visual conflict, also referred to obviously as visual vestibular. So a lot of our training has to do with that, but one of the ways we've always helped people with vertigo, quite often who have marked balance problems, is that we try to compensate with the senses that are still working. So in plain terms for our patients, if you're not getting good sense of balance from your ear, we need to quite often make up for that in somewhere else. One of the main ways you can make up with it is with that proprioceptive sense, or again in vestibular literature, somatosensation. As we discussed with our other athletes and training up here, the shuttle balance provides that quite well. Because it allows for such a high ceiling, and we demonstrated some of the high-level balance activities that we'll either see earlier or later in this tape, sometimes patients or therapists rather are a little bit reluctant to put their patients up here with vertigo. I can tell you from personal experience, as long as they're spotted correctly and you explain what you're doing, they do quite well, and sometimes they're surprised because this plays to their strength. Even though it moves and it's challenging, it gives them somatosensory input and they can do quite well. So any of the demonstrations we did earlier, whatever stance but with vision removed, is going to be good for this kind of patient, and I'd really recommend ramping up very slowly and reassuring and educating that patient, as well as, again, while we're demonstrating with a very healthy, talented athlete here, for our vestibular patients, you're going to want a gait belt and adequate supervision and spotting. We're going to assume that we're doing that here for Amy. So Amy, when you're ready, go ahead and step up here. At this point, let's say she's into her treatment. We've already done all of our standing progression, narrowing the base, closing the eyes, providing perturbation. We're going to show some things that we can do at the end of vestibular rehab to provide some of that sensation. So one of the common things, because the inner ear does tell the brain about head rotation, is people have a lot of trouble with turns, particularly quick turns. What you can do is start that on the floor, but as soon as they're able to turn 360s, you can start to train that here. So we can do that in a number of ways. Amy, I want you to turn a full circle to your left and come right back where you started. Good. So some things that we want to encourage that our patients with vestibular problems will already do is they should be using their eyes to help them make that turn. They should be using visual feedback. If they're not, you can cue them into by putting a variety of ways. Sometimes a laser pointer can be useful to point at spots in the gym. You could put stickers up. You could even just point to things and have people use their vision. But that's a good thing. We don't want to discourage visual use. But again, when they show that that's very well done and doesn't provoke their vertigo, you want to take away their vision. So in this sense, we're using a unique piece of equipment to provide them a very unstable surface, but the way they're going to keep their balance is if the ear is damaged and it can't provide it, and we close their eyes and we can't provide it with vision, this provides a situation where they can train at a high level, but very safely, to make this turn, but with the use of somatosensory sensation. So let's make the turn to your right this time, but go ahead and close your eyes. Good, go ahead and open your eyes. So well done. You can see even for someone without any deficits or vestibular loss, that could be quite challenging. This is something we typically reserve for the end of a course of vestibular rehab. A couple tips if people have trouble with this is if you can make even a partial turn, in theory you should be able to make an entire turn. Sometimes letting people feel that can make them a lot more eager to do the whole exercise. So say if Amy was having trouble, we'd try a few things. Amy, I want you to go ahead and close your eyes, but all I need you to do is turn one step to your left. Good. Now we'll make another little step to your left. Now obviously it's the same exercise, but for many patients, breaking it up into a digestible chunk without mentioning a 360 turn makes them a lot more willing to try the exercise and able to cue in to the cues there. If they were having trouble even with that, you can specifically have them try to sense things. So Amy, what I want you to do now is go ahead and open your eyes and touch the rails. But I want you to just keep everything else in your body the same and just turn your foot, your left foot, out towards me. And now go ahead and turn that back. And then what you can clue people into is that a lot of the proprioceptive input from their foot as well as the hip rotation can be a way to gauge how far they're turning. And so Amy, if you can feel that's about a 90-degree turn, go ahead and when you're ready, I want you to close your eyes, but then just turn your foot towards me. Good. And now I just want you to make the rest of the body match up to your foot. So for some people who aren't cluing into that quite automatically, the right cue can get them using the proprioceptive input. Balance activities could be good for anybody with vestibular problems. If you take away vision, you're biasing compensation for that vestibular problem with somatosensory or proprioceptive feedback. We've done perturbation, but Amy, go ahead and close your eyes. We provide the same perturbation, but if you want to be specific and know how to record what you're doing, this linear translation will more specifically stimulate the otolith in the ear and try to retrain the reading of that function from to have a true vestibular recovery, if you will. You're not making the ear spontaneously heal, you're trying to improve the central nervous system's ability to read the remaining ear signal. Translations side to side or forward are going to be more geared towards the otolith. We've seen how we can do a 360 turn to get rotation, which would be more specific to the canal of the inner ear. Not every patient, say some total hip patients or people who aren't as confident, will be able to make that turn. One way you can do that is, Amy, go ahead and step off. And we've got a prototype here, sort of a lazy Susan bearing that can bear quite a bit of weight, but it'll provide that rotation. We've got traction on that so it can sit atop this and be quite sturdy. But what that gives you is if you talk about what the ear, the vestibular center, normally does for the human nervous system, it provides input on translations, side to side or front to back, meaning linear acceleration, like starting and stopping a car. It also provides information on rotation. So in this case, we're going to train just horizontal rotation, but that's quite often the most provoking for our vestibular patients. So Amy, take your time, use the rails you want, but go ahead and get atop that disc. Good. And when you're ready, go ahead and close your eyes. And I just want you to keep your balance, and I'll spot you here, but then you can just induce a rotation, either slow or you can go fast. Or you can do all the different degrees of freedom that the ear normally tells people about. Good. Now again, very few of our vestibular patients get to the level where we provide that degree of perturbation all at once, but that's another option you got available with this kind of a platform. So one last word about our patients with vestibular problems that we address here in our specialty program. Again, there's a variety of these foam or air discs or you name it that are really great to provide what we call a compliant surface. They could be used with the Shuttle balance, and there's certainly no reason not to, but we want to provide a little food for thought. Is the goal of this compliant surface is to remove the proprioception, that reaction force that goes up through the foot and gives you the stretch and the feel through the tendons. With the compliant surface, if you put it atop of this disc here, atop the Shuttle balance, you can certainly have an athlete stand on, so go ahead and do that. And it will provide challenge. In a sense, though, you have two devices that might be working at cross purposes. You can see that it's clearly difficult for balance, but in terms of we're not quite clear what we're trying to give our nervous system here. The platform is translating, but she's really not going to feel that and clue into the proprioceptive input because the air disc is going to dampen that a little. It's going to comply and take away that feedback reaction force from her feet. So we get this question all the time is, does that make it that much harder to throw the air disc or the pillow or anything on top of here? It certainly could make it hard to balance. It takes you away from the ability to plug and play, if you will, to be sensory specific. That's pretty important for a lot of the patients we see in physical therapy, especially if they have a vestibular condition or vertigo or certain specific sensory deficits after stroke or head injury.